In the last class, we were studying about acute renal failure. In this class, we will study chronic renal failure, that is CRF. Chronic kidney disease, CKD, also called chronic kidney failure, is characterized by progressive and irreversible loss of kidney function that develops over a minimum of 3 months. Whereas acute kidney disease is any decrease in kidney function that happens in less than 3 months. Acute kidney disease is a reversible process if that is treated promptly, whereas chronic kidney disease is an irreversible process because there is irreversible loss of nephrons. Stages of CKD. We know that the normal GFR of a normal person varies between 120 to 130 milliliter per minute per 1.73 meter square of body surface area. In stage 1 of CKD, the GFR varies in the range of 120 to 90 milliliter per minute. In stage 2 of CKD, the GFR decreases to 89 to 60 milliliter per minute. In stage 3 of CKD, the GFR decreases further to 59 to 30 milliliter per minute. In stage 4 of CKD, the GFR is in the range of 29 to 15 milliliter per minute. And in stage 5 of CKD, the GFR becomes as low as less than 15 milliliter per minute per 1.73 meter square of body surface area. This stage 5 of CKD is known as end stage renal disease, that is ESRD. The stage 5 of CKD is the final stage of chronic kidney disease. Here the patient requires renal transplantation or dialysis. Now come to causes of CKD. First is diabetes. Diabetes is the most common cause of CKD. Second is hypertension. Hypertension is the second most common cause of CKD. Third, chronic glomerulonephritis, such as membranoproliferative glomerulonephritis, membranous glomerulonephritis, minimal change disease, all of them can cause CKD. Systemic diseases such as SLE and rheumatoid arthritis can also cause CKD. Infections, especially with HIV, chronic use of non-steroidal anti-inflammatory drugs, and toxins can also cause CKD. Chronic obstruction of urinary tract due to some stones or tumors can also cause CKD. Chronic obstruction in the urinary tract leads to progressive damage to the nephrons due to fluid back pressure, and if not treated promptly can lead to chronic renal failure in due course of time. In fact, any acute kidney disease if not treated promptly can gradually lead to chronic kidney disease over a long period of time. Now come to diabetes. Diabetes is the most common cause of CKD. It is the number one cause of CKD and is responsible for death in more than 10% of all diabetic patients. The complication which occur in kidney due to diabetes is called diabetic nephropathy. Now come to pathogenesis of diabetic nephropathy. In diabetes, there is high blood glucose level. The glucose attaches or sticks to nitrogen group of amino acids, leading to formation of advanced glycosylation end product. This process is known as non-enzymatic glycation. With the formation of advanced glycosylation end product, there is cross-linking of collagen, leading to damage to vessels. This particularly affects the efferent arterioles and cause efferent arterioles to become stiff and narrow. In the photo we can see there is afferent arteriole which brings blood. The afferent arteriole breaks into glomerulus and blood escapes the glomerulus through efferent arteriole. In diabetes, the efferent arteriole become stiff and narrow. So there is narrowing of the efferent arteriole. So blood in glomerulus find difficult to pass through the efferent arteriole. Because of the stiffness of the efferent arteriole, the blood in the glomerulus find difficult to pass. So there is increase in pressure within the glomerulus and there is intraglomerular hypertension. Pressure inside the glomerulus increases. So more and more of blood is filtered through glomerulus and there is hyperfiltration. So initially the GFR increases. But later on, due to intraglomerular hypertension, there occurs damage to mesangium. With damage of mesangium, there is activation of cytokines and there is formation of free oxygen radicals. This causes inflammation. With inflammation, the mesangial cells are activated and it secretes extracellular matrix protein such as collagen and fibronectins and laminin. This leads to mesangial expansion and glomerulosclerosis. So slowly there is hardening and thickening and a scarring of the glomerulus. With mesangial expansion, the spaces between podocytes, food processes also expands, leading to proteinuria. Initially, it is microscopic proteinuria in the range of 30 to 300 mg in 24 hours. But later on, when the damage to the glomerulus is more, it becomes overt proteinuria. That is, more than 300 mg of protein comes in urine. Due to glomerulosclerosis, that is hardening and scarring of the glomerulus, the nephron lose the ability to filter blood. So finally, GFR starts decreasing. Now the GFR decreases and finally patient reaches stage 5 of CKD, that is end stage renal disease, where the patient requires renal transplantation or dialysis. Second, hypertension. With hypertension, the wall of the artery supplying the kidney thickens. This thickening of the artery occurs from the level of arcuate artery, interlobular artery, and afferent arterioles. These are arcuate arteries. This is interlobular arteries, also known as straight arteries, and this is afferent arteriole. So in hypertension, there is thickening of these arteries and arterioles. There occurs hyaline arteriosclerosis in these arteries. Hyaline arteriosclerosis is homogeneous eosinophilic thickening. There also occurs proliferation of smooth muscles of tunica intima, resulting in narrowing of the lumen of these arteries. So when there is narrowing of the afferent arteriole, there is reduction in blood supply to the glomerulus. So when this afferent arteriole or interlobular arteries or arcuate arteries thickens, the blood supply to the glomerulus decreases, as a result of which there is necrosis and cells die. There occurs atrophy of the renal parenchyma. The glomerulus shrinks. There is deposition of collagen in Bowman's space because the mesangial cells are stimulated and they start depositing mesangial matrix, leading to fibrosis and nephrosclerosis. So slowly there is deposition of extracellular matrix, leading to fibrosis and nephrosclerosis. So GFR decreases. Slowly the GFR again decreases and finally reaches the stage 5 of CKD, that is end stage renal disease, where the patient requires renal transplantation or dialysis. Third, chronic glomerulonephritis. Example, membranous glomerulonephritis, membranoproliferative glomerulonephritis, IgA nephropathy, and rapidly progressive glomerulonephritis also cause CKD. Here the glomeruli is reduced in number. There is presence of hyalinized tuff of acellular eosinophilic mass and tubules show atrophy. Clinical features of CRF. We have seen that in CRF, GFR decreases. With decrease in GFR, less urea is filtered out in urine. So it accumulates in blood, leading to azotemia. This excess of urea in the blood causes general symptoms of nausea and loss of appetite. So when this urea accumulates in blood, there occurs general symptoms such as nausea and loss of appetite. Excess urea affects the central nervous system, leading to encephalopathy. Excess urea in blood irritates the pericardium of heart, leading to pericarditis. Platelet function is deranged, leading to bleeding. Because of excess of urea and these nitrogenous waste products, the platelets fail to stick together. That's why bleeding occurs. The urea crystals deposit on skin as powdery uremic frost. Second, with decrease in GFR, there is less excretion of potassium, leading to hyperkalemia. That is, the potassium level rises. Hyperkalemia causes muscle weakness, cardiac arrhythmias, and fibrillations. With decrease in GFR, there is accumulation of hydrogen ion leading to acidosis. Thirdly, when GFR decreases, less fluid is filtered out, leading to accumulation of fluid in body. Further, with decrease in GFR, kidney release renin, which leads to activation of renin-angiotensin-aldosterone system, leading to absorption of more of water and sodium. And this results in further edema and increase in blood pressure and hypertension. Kidney produces erythropoietin, which stimulates production of red blood cells from bone marrow. Decreased production of erythropoietin by kidney produces normocytic normochromic anemia. So in chronic kidney disease, there is less production of erythropoietin. So patients do have normocytic normochromic anemia. Secondly, kidney produces active form of vitamin D, that is calcitriol, also called 125 dihydroxycholecalciferol. It has important role in calcium homeostasis. It increases blood calcium by increasing absorption of calcium from intestine and kidney. In CKD, the calcitriol level decreases, so there is hypocalcemia. So there is activation of parathyroid hormone, which try to prevent low calcium level by mobilizing calcium from bone. This leads to bone destruction because of osteoclastic effect and renal osteodystrophy. So these were the clinical signs and symptoms associated with chronic renal failure.